Hello, I'm Dr Arulmozhi Varman. I'm from Chennai. I have a hospital that's called Umai Clinic. We've been in practice for over 35 years now. So we are a cutting-edge hospital in India where we cater to cataract, glaucoma, refractive surgeries, vitreoretinal surgeries, oculoplasty, cornea, and all subspecialties of ophthalmology.
This is Dr. Varman from Chennai, India, and he was one of the first people to do phacoemulsification in India, and over the years he's continued to develop and introduce new technologies, including SLT for glaucoma, epi-on crosslinking, and of course still a major developer of phacoemulsification. So welcome, Dr. Varman.
Thank you for having me here.
And can you tell us a little bit about your practice and how you got started?
Okay, my practice is about 35 years old and started off at a time when ECC was ruling the roost and then phaco was just coming in. So I was an earlier, very early proponent of phacoemulsification, took on to it, and I believe I did the first multifocal IOL implantation in India. And even now my practice is about 40 to 50% multifocal IOLs. We do a lot of premium IOLs, toric IOLs. And we did also start off LASIK, one of the early LASIK users of India. And I think I'm among the first 6 people to start using SMILE in India. And then SLT probably was the second or third person to start SLT in India. And I'm a strong proponent of SLT as a treatment for open angle glaucoma.
Okay. Can you tell us a little bit about how phacoemulsification has developed over time and what's new in it now that's interesting and exciting for you?
Okay, at the time that I started doing phacoemulsification, you would probably use 400, 500 ml of fluid to do one surgery. It would take about 20, 30 minutes, sometimes 40 minutes, with the cornea not looking very good the next day. From there we've come down to now using something like about 25, 30 ml of fluid, and the surgery is all over in less than 6 minutes, with the cornea looking pristine 1 minute after surgery, and the patient gets back normal vision right away. And we now add on really high-end lenses, so you can correct spherical errors, astigmatism, presbyopia, aberration-free vision to the patient. So we've come a very, very long way. And what I'm looking forward to is the innovation in multifocals, where we're going to get rid of the rings on these lenses, and we're going to have lenses that work on aberration principle, which are going to give brilliant vision across all distances with no loss of contrast sensitivity. And I believe those lenses are just about around the corner.
Okay. Can you tell us a little bit about how the instrumentation has developed over time and what the effect of that has had on improving the efficiency and speed of phaco?
No. Very tiny, small steps is what, many of these steps is what brought out, if we stick to cataract and phacoemulsification, simple developments of low compliance tubings, wider bore tubings for inflow, better sleeves and tips on the phaco machine, which really changed the efficiency of the machine. And of course, other electronic components, the smart pump, where the reaction of the pump is so fast that chamber stability is immensely better. All of these are small. Even if you make the best pump and you don't have the right tubing, you're not going to get the best results. You have everything that's perfect, but you don't have a phaco tip and sleeve that doesn't match. You're not going to get there. So these are multiple small steps. So all of these put together is what made the whole procedure very safe, very predictable, and very fast.
Are you using pre-choppers or any of that at this point?
I'm not a big fan of pre-choppers as such. My technique is to use direct chop. And in direct chop, you need to work with high vacuum, high flow, and you need to have a tip that gives you excellent hold on the nucleus to chop it, whether it's a soft or a hard cataract. And I'm one of the users for a very long time. I think I've been using the harmonic tip from ASICO for over about 8 or 9 years. This, a lot of people think the harmonic tip is primarily meant for a hard cataract. No, it will work even for a soft cataract. It will even work for a prelex where there is no cataract at all. The tip works very well because it can give a large area of hole, at the same time give a very low outflow and keep the chamber very stable. So you can work with high vacuum, high flow, and get brilliant chamber stability. I added to that, the tip is very efficient in emulsification, that it brings down the emulsification time, that's the EPT of any given cataract, by a factor of somewhere between 5 and 3.
5 and 3 times.
Exactly.
So you're using much less energy.
Much less time, much less energy, much less fluid, it works that way.
And how does that affect your productivity as a surgeon?
Productivity is one. The first thing is it saves time, but that's maybe I can do more surgeries in a given time. But what I'm really impressed about this kind of technology is the chamber stability, less fluid turbulence, is that you have safety to the patient.
Right.
So your incidence of posterior capsular ruptures come down dramatically. Your incidence of wound burn becomes 0. Your incidence of corneal swelling and striate keratopathy comes down tremendously.
Right.
And these are something that you value more than doing maybe 2 or 3 surgeries more in 1 hour.
Right. So you have fewer complications.
Much
better
complications,
outcomes.
and in difficult situations.
Right.
I can do hard cataract in a small pupil without using a pupil expansion device with the newer technologies.
Okay, great. You recently published some SLT literature, or you were referring to some that was
Yes,
recently published. Can you tell us?
I've been doing SLT for over 10 or 12 years, ever since it came out on the market. And initially we were doing 180 degrees, and everybody said 180 degree of SLT would do, and that you would have to just do the minimum energy possible, just keep your energy at 0.3 and keep increasing till you just see a single champagne bubble and come down and do sub-threshold treatment. I think that's where we failed. On 2 counts, an SLT was doing sub-threshold treatment, 2 doing it on 180 degrees, 3 and doing it only on patients who have burnt out glaucoma. That means they've been treated for a decade or 2 with drops of a surgery, nothing worked, and you do SLT. I started doing it differently as a first line even 10 years ago, and I started doing suprathreshold. So I started 1, 1.1, 1.2, I go to 1.3. I want to see champagne bubbles. I want to see bubble formation in the trabecular meshwork. I do it with high magnification. I have to see bubble forming into the trabecular meshwork. And I do 360 degrees. I do somewhere between 120 to 140 shots per patient. And my success rate on SLT is over 92%.
So you get people off drugs, or
Totally off drugs.
totally off drugs?
And the best part about this kind of SLT is suprathreshold treatment is you can take somebody who's got a low tension glaucoma, who has a starting pressure of 12, and take him down to 10 or 9, which is brilliant.
Right.
Or I can take somebody with ocular hypertension who's got 30 or 32 and bring the person down to 16,
Okay.
which is just amazingly good. So you can work on all the spectrum, starting with the standard glaucomas, the ocular hypertensives, and the low tension glaucomas.
I guess that's good for patients
Yeah,
too, that
that's
they
really
don't have
good.
to take the medications.
And not only the medication, the IOP control is 24 hours. It's not
24
like the
hours,
medicine, you miss it once and then it starts to fluctuate. It stays 24 hours, 7 days a week, 365 days of the year.
That's great. So you also brought a LASIK into India early, and now you're working with SMILE.
SMILE,
Can you tell us a little bit about the 2 technologies, where you see them fitting today, or where they're going?
I have, I would say, the cutting edge in both. I have the SMILE machine, and I have the latest iDesign 2, which is the one of the best customized software for LASIK with the femto flap maker. But I'm a great fan of SMILE. We look at what SMILE does not induce any aberrations, brings down the aberrations. The treated area, 6.5 millimeter, is even all through, which is unlike LASIK. So as of now, I'm a big fan of SMILE.
Okay. Can you talk a little bit about new instruments, or the kinds of instruments that you've developed over the years to facilitate these?
Okay. I have developed several designs of choppers, particularly 2 types. I believe in the long, sharp choppers, which are at least 1.75 millimeters long, so you can do straight away you can do a chop in even a hard cataract. I have developed instruments for SMILE. The SMILE procedure is very surgeon dependent, and if one is not very careful, there can be a lot of complications in the dissection of the lenticule, and if the lenticule tears, it can be a kind of a disaster. The right instrumentation can make a great difference in that.
So can you tell us a little bit about your design, or what kind of challenges you had and how you met those with?
The design is going to be only the separator and the initial dissector, which has to be not too long. It should be not too sharp, so you don't go make a false passage anywhere. You're able to delineate both the upper and the lower dissection planes perfectly. And once you've done that, you want a long, smooth dissector, which need not be sharp, which should be only semi-sharp or smooth, that can dissect out the planes without damaging the lenticule.
So that was something that really didn't exist initially. So.
Yes. And on Epi-on cross-linking,
right.
I believe Epi-on cross-linking will work under two circumstances. I don't believe that when you put the drops on the cornea and then you keep on putting it for 10 minutes or 20 minutes or 30 minutes, it keeps running off the cornea. You tell the patient to keep the eye closed, and you hope that the drug would penetrate, riboflavin would penetrate into the stroma. I believe in creating a well. I've designed an instrument where you place it on the cornea, you creates a well, and you put the drop in, and you keep the level of riboflavin about 1 millimeter to 2 millimeter height, and that penetrates into the cornea consistently with great accuracy in exactly 10 minutes.
Okay, and that's with the Epi-on.
So one, in Epi-on you want the penetration to be good. Two, you want enough oxygen penetrating into the stroma, because the very process of cross-linking eats up oxygen.
Right.
So what I do is to first bubble oxygen through the riboflavin in the syringe for about 5 to 10 minutes. Then I've designed an instrument where the well, oxygen is bubbled into that level of riboflavin very slowly, continuously. So riboflavin, which is enriched in oxygen, enters into the corneal stroma, increasing the oxygen content of the corneal stroma. You take it off, then you do the accelerated cross-linking, which only takes about 3 to 4 minutes. So during that period, I still continue to blow oxygen on the cornea, and I don't put any riboflavin, because enough riboflavin is already gone in. Then you get, with this kind of a technology or a technique or an innovation, I believe that Epi-on results are as good as Epi-off.
Okay. What kind of results are you getting with Epi-on versus
It's comparable to Epi-off.
In
my practice, it's absolutely comparable to Epi-off. No difference whatsoever.
So no similar rates of progression?
Exactly the similar rates of
Okay. Well, thank you very much.
Thank you.